It's my pleasure to welcome all of you for the hepatitis C workshop today. So why we have this workshop? Because as you know that the hepatitis C, when you look at this figure, we have hepatitis C much more than HIV. So hepatitis C and hepatitis B, they are a big silent killer for our patients nowadays. So now with the hepatitis C, with the new treatment guideline, so it's changed landscape of hepatitis C treatment. So now hepatitis C can be treatable and can be curable. So if you look at this figure, hepatitis C is easily to be cured actually, because they are living in cytoplasm compared to hepatitis B or hepatitis or HIV. Even now, we still don't have the curable for that. And co-infection, so in this population, is increased liver fibrosis, is increased, so in co-infection, they have higher viremia and increase the resistance or transmission, increase the transmission from partner to partner, or from mother to the baby, if the mother has HIV and hepatitis C together, and decrease the chance of hepatitis C spontaneous clearance, especially in a patient with low CD4 cell count. And also, with the co-infection, the liver fibrosis progression is faster than non-HIV. And especially in genotype 3, is associated with a higher liver fibrosis than other genotype. And the other important thing is that for the co-infection, they have higher extrahepatic manifestation compared to hepatitis C mono infection. So you can see that from head until toe, they can have many things happen if hepatitis C cannot be treated. So especially chronic kidney disease, or in the patient with low CD4 cell count or poor CD4 cell count response. So maybe because of hepatitis C or diabetes, so it's happened higher among co-infection. And so right now, we have so many drugs available, very simple. It's just oral drug can be taken as a one pill a day, and efficacy is more than 95%. And some regimen can be used for pan-genotypic, can be used for all. And right now, we can access to cheap or generic hepatitis C for many countries in this region, including Thailand. So we can access to this drug. So for the drug, so you will listen to our speaker later. And so since we have the new drug, so nearly everyone with hepatitis C can now be treated successfully. And the new DAA efficacy and treatment duration is similarly between HIV and non-HIV. Just thinking about some issue, for example, cirrhosis maybe is higher in co-infection because, as I said, that HIV accelerates the hepatitis C disease progression, and drug-drug interaction, and also reinfection in some population, especially in young MSM population. So this is good for today that we have a workshop, and we have 4 well-known speakers to be with us today. And today is very special because we have 2 hepatologists to be with us. So just prepare your question to ask them. So for today's agenda, we will start with the case about the hepatitis C regimen simplification, about the drug resistance. Is resistant associated variants or RAS important in this area? This will be delivered by Tantira Pilas Visut from the Songkhla from the Prince of Songkla University. And next topic will be drug interaction with Professor David Berger, and access to hepatitis C treatment from Gideon, my good friend, and also he's very good on the access to drug. And finally, we will talk about the cirrhosis management, how we do that by Dr. Piyawat Gomonmit. So we just start hepatitis C workshop now. So for the first speaker, Ajahn, you would like to be in the panel. So I would like to invite Professor Pilas Visuto. So he is very well-known hepatologist in both hepatitis B and hepatitis C field. He represents Asian Congress on the hepatitis B and hepatitis C. For us, in terms of HIV expert, so today this is a very good day for us to listen to him and to ask him about our patient. So I will start with my patient first. So we will start with the case, and he will respond on that. And finally, he will have like a mini lecture related to the topic later on. Just start with the first case. The young female, 17 years old, so HIV negative, and mother was co-infection and never treated for hepatitis C. He has a high hepatitis C RNA. I'm sorry, this is genotype 1B actually. Genotype hepatitis C genotype 1B, and borderline ALT, AST, and no cirrhosis. Normal kidney function. For hepatitis B, he has S antigen negative, but anticore positive, and no cirrhosis on the ultrasound. So the question for Ajahn is that, so which treatment option would you recommend to this patient?